Neopharynx that we have formed, there can be stricture that may require dilatation or maybe food modification. Depression, certainly you will have to look into, give more time. But apart from that, these patients have chances of hypothyroidism because radiotherapy was given to the neck. So whatever residual thyroid would be there, it may have undergone ablation. That may lead to, again, requirement for thyroid replacement.
Great. So I think we need to conclude here, and maybe if you all have any questions, we'll. Yes, please.
Just a minute. How many of you want to join oncology after summer school? How many
All
of them interested?
100%.
You join oncology? Nobody from this side? And how many of want you to surgeons?
Yeah.
100%.
Go for it. Go for it. Okay.
It was just a fun. And don't take it.
Good afternoon, sir. I'm Devakar, surgery resident from Nair Hospital. I have two questions. First is that we talked about frozen section. We do operate a lot of thyroid patients with Bethesda grade 3 or 4, where there is query follicular neoplasm. We do hemithyroidectomy and send the specimen for frozen section, and it turned out to be follicular adenoma. We leave the patient there and itself, and later on histopathology, it turned out to be follicular variant of Pepsi or follicular carcinoma. So what should be the ideal treatment in such cases where FNAC is also doubtful and frozen is also doubtful?
Basically, saying that thyroidectomy done, hemithyroidectomy done, and it is a histological surprise that it comes as a follicular variant of papillary carcinoma. Should we go ahead to remove the remaining lobe and do the central compartment neck dissection, or leave it at that? This is the question. So again, this goes on the risk stratification. You have to do the risk stratification based on whichever criteria you use. If the patient falls into the high risk, certainly you should go in again and do a completion thyroidectomy so that you make the patient suitable for radioactive iodine therapy. Like here we are talking about the radiotherapy, there we are talking about the RAI, ablative therapy. If the patient is in low risk category, it depends which criteria you use, you just stop at hemithyroidectomy. And if it is intermediate, come back to the multidisciplinary joint clinic, have a long debate, you will never get an answer.
I think the answer.
Second thing is,
I think the question was the reliability of frozen section.
yes. The second thing is, should we rely on frozen section, or we should go ahead with total thyroidectomy at the first sitting only?
So I would, to answer that question, I don't do frozen sections for diagnostic lobectomies, because we have what we call, similar to the Bethesda classification, we call it the thigh classifications, usually thigh 3A and A and thigh 3F. Follicular adenoma versus follicular neoplasm. We just go ahead, we do a thyroid lobectomy, get the histology, and then do a completion if they have high risk factors. I am not aware of any frozen section guru in thyroid for thyroid pathology.
Second thing is, does the grade of the tumor, like this patient was poorly differentiated squamous cell carcinoma. Had it been a well differentiated or a moderately differentiated, would the grade change the modality of the treatment?
In thyroid?
No, in CA larynx.
No.
Thank you, sir.
In the larynx or the thyroid?
So there you have to look at what do you mean by the superior, entering the superior mediastinum. If you think it's disease that's got a subglottic extension and that's the primary has gone in, or is it superior mediastinal lymphadenopathy, because there is involvement of the cricoid, and if the post-cricoid was involved, level 6 would always be at risk. So there you'll also have to determine about whether you're going to do surgery as the first treatment, because here you have to remember that the thyroid cartilage is destroyed. It's T4, surgery is the treatment of choice. So there the surgeons will also have to decide about your lower margins, whether you can get an adequate lower margin, because that's where they may not want to go in. No, but it's essential.
If it was very advanced and it was not resectable, like we discussed, we are going to plan the treatment as surgical treatment only if you're going to get a good clearance. If we were to determine on imaging or clinical examination that we wouldn't be able to get a clear margin, the surgery would not have been in consideration. It's very, very rare situations wherein we would go in for surgery wherein we know that we may end up with a gross disease left behind. It's very uncommon. Yes, it may either go for concurrent chemoradiation if it is feasible, or go for palliative. So I think we have had a good discussion. Oh, you have still a question? Okay. Okay. Just 1 minute. That group has not asked a question since a long time.
They're the quiet
Good afternoon,
group
sir.
over there.
And myself, Dr. Satish from Southern Hospital, and I'm surgery resident. My question is not regarding the head and neck cancer, and how does the multidisciplinary team in Tata Memorial functions in OPD basis and day-to-day basis? How does it functions in OPD? And is it something like a set of processes sit in OPD and each and every patient comes in and we discusses how it functions?
This is how it functions. We actually sit around and the patients are coming forth. The residents prepare the cases. And they present the cases to us, and we discuss out what are the pros and cons for every discussion, whether it's investigation. Pardon? Yeah, and you all are going to have a tour, so you all will actually sit through the joint clinics with us in the OPD, and you all will understand the process. And bear in mind that this process is done in every unit daily. So in Tata Hospital, a head and neck service does a joint clinic every day from Monday to Friday. So we have 3 working units, and the joint clinic is done daily. So you might go through the private side, the general wing, and both the sides you would have a joint clinic.
No, thank you, sir.
Okay.
Myself, Dr. Nikhil, ENT resident from BJGMC Pune. I just want to ask, is the emergency laryngectomy practical or theoretical? Just
Emergency laryngectomy?
so they have given that within 24 hours we decide and do the laryngectomy. And the patient came in stridor.
See, if you are working in Tata Hospital, we can do that. But what happens if you are not in a system where emergency such surgeries can be done? You require anesthetists, you require everything in the theater.
Yes,
Then I would suggest that very rarely, how often we would have done emergency laryngectomy. It's not an emergency.
Yes.
If there is a stridor, tracheostomy is an emergency. You can do tracheostomy.
Yeah, we do the tracheostomy.
And you can do the surgery next day. But if you have the expertise and you can do in midnight, 12 o'clock, emergency laryngectomy, I don't think Devendra will ever come for that.
But I think
So it's just a theoretical concept.
just to highlight that point, because I'm an editor for the International Journal of Surgical Case Reports, and there was a submission of a patient who had an emergency laryngectomy because they came in with stridor. They thought it was a squamous cell carcinoma, so without histology, they proceeded to do a laryngectomy, and then it came back as a chondrosarcoma. So this patient had a total laryngectomy, bilateral neck dissection, and for the wrong pathology,
Had
essentially.
the audacity to write a case report.
And they had the audacity to write a case report. It was unbelievable. And when I sent it back to them and said, well, I thought it was a good learning point, so we accepted it because I thought it would be a good learning point of how not to do things. Okay.
This brings us to the point that there's no such thing as a bad publicity.
Yeah, exactly. And when I asked them the question, why didn't you do a tracheostomy, for example? They said no because we thought it was an SCC, and they still refused to learn the point that, you don't need to do an emergency laryngectomy. You can do a tracheostomy, at the same time, so do an awake tracheostomy, put the patient to sleep, assess the tumor, take a biopsy, get urgent histology. Within 24 hours, you should be able to get your histology back. You can get your staging imaging, and then you can plan the next treatment.
Thank you, sir.
Okay, so thank you very much. It's been a great learning for us. So I'd like to thank all my panelists, Dr. Ofo here, Dr. Sarbani, Dr. Nilendo, Dr. Abhishek, Dr. Devendra Chaukar, Dr. Shiva, and Dr. Shraddha, and Dr. Pankaj. Thank you very much.
On behalf of our organizing team, may I request all the DMG member to join us for food. Madam. please don't move. We have one more 15 minutes lecture for you all. Hello. So Dr. Amit Pulkar is from Dogs Bay. Whosoever has a query regarding your upload, your view, anything, iPhone, please ask him. He'll help you.